I hope we all are caffeine intoxicated by now. I couldn't get it, I'm sure, but I hope you all are. Moving on to our next topic. Before we move on to our next topic, we have the panel discussion at 7 p.m. today. Would request you all to kindly attend the same. Moving on to our next topic, I would like to invite Dr. Padma, who's MBBS, MD, Professor and HOD in Saptagiri Hospital and family consultant. And Dr. Rajesh Kiran, who's consultant nephrologist, People Tree Hospital and Chetan Diagnostics.
Good evening, everyone. So, a warm welcome to everyone. I'll be welcoming Dr. Mathew John, who is a senior consultant endocrinologist at managing partner at Providence Endocrine and Diabetes Specialty Center, Trivandrum, who's trained in endocrinology from King Edward Memorial Hospital, Mumbai, and in advanced diabetes therapeutics and technology at International Diabetes Center in Minneapolis. He's a member of Endocrine Society of India and the Asia Pacific Pediatric Endocrine Society, a research society for the study of diabetes in India, and ISBMR as well. So, key opinion leader and faculty in scientific forums both in India and abroad. So, we welcome you, sir, and please ask you to proceed with the session. Thank you.
Thank you, Doctor, for the introduction. Special thanks to Dr. Murthy for inviting me. So, this is the topic for the day, redefining diabetes treatment, oral semaglutide and its impact on cardio-kidney metabolic syndrome. So I've been contracted by Novo Nordisk for this meeting. So these are the areas which I'll be covering in the next 20 minutes or so. We look at CKM syndrome and its stages. This is an evolving concept. I think it's very important that we know it. We look at the multifactorial actions of GLP-1 arrays in the CKM spectrum. We look at impact of oral semaglutide in glycemic and weight management. Look at the evidence supporting oral semaglutide in cardiac kidney metabolic risk reduction. And finally, we will raise a question whether oral semaglutide holds the promise of becoming one of the prime solutions in diabetes and CVD treatment. So this is the way in which I'll be running my talk. Now coming to CKM. So what exactly is CKM? CKM syndrome is a systemic disorder characterized by pathophysiological interactions between metabolic risk factors, chronic kidney disease, and cardiovascular system. This leads on to multi-organ dysfunction and high rate of adverse cardiovascular outcomes. So CKM syndrome has been very recently described and very recently been defined in terms of what exactly it is. But we know that these sort of associations between the heart and the kidney, the associations between adverse metabolic outcomes and heart and adverse outcomes between adverse metabolic milieu and the kidney has been very well known. And it has been known by different names over a period of time. In 2023, the American Heart Association brought out a presidential statement which actually tried to define this entity and tried to define treatments and modalities to control and prevent the disease. Now, this is a very complex slide, but the complexity is itself a part of CKM syndrome. To show that how obesity leads on to type 2 diabetes and how obesity, hyperglycemia can lead on to both chronic kidney disease and to cardiovascular disease, and the interactions between these two diseases which can worsen the overall state of affairs for the patient. Add on to it, different things appear during the course of CKM progression, which includes metabolic, MASLD, sleep apnea, weight gain, etc., which can all worsen the entire spectrum. Now, this is a major problem. If you look at the right side of the left side of the thing, to see that a large number of people living all over the world have at least one or more of the components. And again, you would see that many of the components of this syndrome are not properly managed, or rather we have people with uncontrolled disease. We have 50% of people with type 2 diabetes who are suboptimally managed, 90% of people with type 2 diabetes who have overweight or obesity. And you can also see that around 65% have MASLD, 40% with CKD, and around 32% with CVD. So this is a major public health problem in terms of both the risk factors and the disease per se. So what drives the CKM syndrome? So it's the abnormal fat mass or the fat inflammation which actually drives the thing. So this complex picture, you can start deciphering it from the center, where it shows the adipose tissue inflammation, and which the inflamed adipose tissue secretes various chemicals or cytokines, which can lead on to insulin resistance, hypertension. This can also lead on to atherosclerosis, cardiac dysfunction, and abnormal ventricular remodeling and fibrosis. Increased fat mass can lead on to hypertension, worsening of kidney disease, and there can be a continuous interaction between the kidney disease and the cardiovascular disease, and each of it driving the other thing to progress forward. There's further things like elevated blood volumes, hypertension, sympathetic activation, etc., which can compound the entire problem. Now, going through the stages of CKM, it's important to know this. One is something called stage 0, where there's no risk factors. So this is a person who is having no risk factors for CKM syndrome. There's no hypertension, normal glucose intolerance, body mass index and waist circumference is between normal limits, and the person is healthy. So for this person, the primordial prevention starts there in terms of ensuring a good diet, lifestyle, exercise, etc. The second stage, or the stage 1, as the CKM starts, is where you have increased fat mass, obesity, overweight, abdominal obesity, and you could have something like an impaired fasting glucose or an impaired glucose tolerance. So that is stage 1. Stage 2 is where you have the metabolic factors which are already there, established. You have diabetes, you have hypertension, you can have hypertriglyceridemia, or you can have moderate CKD at that stage. Then comes stage 3, where you can have a subclinical atherosclerotic vascular disease or subclinical heart failure. When you say subclinical atherosclerotic heart disease, that may be an angiographically detected a cardiac plaque. It may be a carotid plaque can be there. The intima media thickening can be there. When you say subclinical heart disease, it can be a left ventricular hypertrophy, it can be an elevated NT-proBNP, something which is very mild, which has not reached a clinical symptom. And when you reach stage 4, you have the entire spectrum of disease. You can have an established heart disease, established heart failure, atrial fibrillation, stroke, or peripheral arterial disease. So this is how the disease progresses. And at every stage, we have an opportunity to interfere with CKM syndrome so that it doesn't move on to an end-stage disease. You can start with stage 1, you can start with stage 2. So wherever you see the patient in the spectrum, you have an opportunity to get the disease under control. So addressing the weight will form the cardinal area which can reduce most of this. Reducing the weight can lead on to reduced blood pressure, improved lipids, reduction in blood glucose levels, reduced insulin resistance, and reduced inflammation. So weight management will form the center of all this. Now, when it comes to GLP-1 RAs, I'm sure there are going to be other GLP-1 RA talks also in this conference. It acts by various mechanisms on the CKM syndrome and in terms of the fat mass. It acts on the appetite regulation and weight loss. Most of this action happens in the center, in the hypothalamus and also in the hindbrain, which is involved in appetite regulation. It reduces the hunger, it reduces the food cravings and the energy intake on one side and improves the satiety. So this is primarily a central mechanism. There's also a gastrointestinal component to this. This is one place where GLP-1 RA acts. When it comes to the cardioprotection, You can see the central nervous system part I just told you. When it comes to cardiovascular protection, it can have favorable effects directly and indirectly. It can act in terms of the kidney in terms of reducing the albuminuria. It can reduce the blood pressure. It can increase the microvascular coronary flow. In the atherosclerotic plaque, it can reduce inflammation and improve the plaque stability. And in the myocardium, it reduces the inflammation and improves the glucose metabolism. In the liver, it has got beneficial effects in terms of lipid metabolism, reducing the liver fat. When it comes to direct action on the cardiovascular system, you saw the indirect actions, the direct actions. There can be indirect actions here also in terms of reducing the weight, the blood pressure, and the glycated hemoglobin. You can have direct effects on the endothelium in terms of reducing the vascular inflammation, reducing lipid accumulation. We know that vascular smooth muscles are the prime culprits in terms of atherosclerosis initiation and progression. It has got actions there. It has got improved endothelial, it improves the endothelial dysfunction by improving various aspects of molecules like nitric oxide, VCAM, etc. So overall, it has got direct and indirect actions on the vascular system. How has this translated into clinical outcomes? This is a meta-analysis of multiple cardiovascular outcome trials of GLP-1 RAs. You know that all the molecules in the GLP-1, most of the molecules in the GLP-1 RA class has got a cardiovascular outcome trial. So overall, you can see a 14% 3-point MACE reduction, that is major adverse cardiovascular events. And if you look at the individual components of these cardiovascular events like fatal or non-fatal MI, cardiovascular death, fatal or non-fatal stroke, you can see all these components have been improved with the use of GLP-1 RAs. This is the entire meta-analysis of patients put together. It has got nephroprotective action. We now have very committed renal outcome trials like FLOW, but otherwise also there have been overall data has been building up for GLP-1 RAs over the period of years now. Indirect effects are always there. Glycemic control, reduction in blood pressure and weight control, all of this have translated into outcomes for the kidney. And increases in natriuresis, and also reduces, it has got direct effect on the kidney in terms of reducing oxidative stress and improving systemic and renal inflammation. So this is the effects of GLP-1 RAs on the kidneys. Now coming to MASLD or non-alcoholic fatty liver disease, as we know it earlier. Again, there has been direct effects and indirect effects. Indirect effects have been in terms of weight loss, which has translated into reduced steatosis, reduced liver inflammation. There have been smaller studies in terms of looking at pathology, histopathology, improvement in people with MASLD. And there are direct actions in the liver in terms of lipid metabolism. GLP-1 RA, GLP-1 receptors are not found on hepatocytes. So most of the mechanisms in terms of lipid movement within the liver leading on to reduced liver inflammation. Now coming to overall systemic inflammation, you would have realized by now that overall reduction in adiposity, overall reduction in lipid inflammation translates into reduction in systemic inflammation, and that is also seen in people with obesity who are using GLP-1 RAs. So how has this translated into clinical recommendations for patients? So you can see different organizations. If you look at the American Diabetes Association, which most of us are very familiar with, we know the two sides of the ADA algorithm. On one side, you have people with high ASCVD and high CV risk for whom GLP-1 RAs are recommended, irrespective of their glycemic control as a cardiac protective agent. In the kidney guidelines, the KDIGO 2022, after SGLT2 inhibitors, the next preferred agent is the GLP-1 RA. When it comes to the cardiovascular guidelines, the 2024 and 2023 ESC guidelines, European Society of Cardiology, again, independent of A1C reduction, GLP-1 RAs are preferred in terms of cardiovascular risk reduction. In the liver guidelines, that is the EASL, EASO guidelines with 2024, again, GLP-1 RAs are to be used. They are not the indication drugs, but they are to be used in people, preferentially in people with diabetes and fatty liver disease. So these are the different organizations which has come out with this recommendation. Now coming to the role of oral semaglutide in glycemic and weight dual management, the pioneer group of trials we are all familiar with. I think most of you would have listened to many of these talks earlier also. We are looking at two aspects here. One is the A1C reduction. Up to 1.5 A1C reduction is seen in people who are using oral semaglutide, and up to 5 kg weight loss also is seen in people who are using oral semaglutide across various trials. So if your baseline A1C is more than 9%, then the reduction in A1C translates to more than 2.6%. So overall, a very good glycemic agent for glycemic reduction and also for weight management. If you look at a composite endpoint, because we are not treating patients just for A1C reduction, we are not just treating patients for a particular aspect, we are looking at the totality of the benefits that you get. So A1C reduction of more than 1% and a weight reduction of more than 5% is seen across the entire pioneer trials of oral semaglutide, and it's always more than the placebo group, irrespective of whether your placebo is a GLP-1 RA like liraglutide, or your placebo is or rather your comparator is a liraglutide or your comparator is empagliflozin. Again, wherever it is, the percentage of patients achieving targets are much better with oral semaglutide. There has always been a concern of loss of loss of muscle mass with the use of GLP-1 RAs, but there is data, at least from smaller segments of patients. This is a 26-week open-label real-life prospective study to show that the overall fat mass lost is much more than the fat-free mass lost in people. And there's also a reduction in visceral fat mass, which is a bigger proportion of the overall fat mass, or rather, a preferential visceral fat mass loss is seen, and a preferential fat to skeletal muscle loss has been seen in patients who are using semaglutide. Now, coming to the CKM syndrome, which we discussed earlier, it reduces systolic blood pressure, various mechanisms. I told about the renal mechanisms, the indirect mechanisms on reducing weight itself can reduce the blood pressure, and that translates into various benefits for people with diabetes in terms of micro and macrovascular complications. Lipid profiles are improved. Predominantly, you can see that compared to the placebo, there's an improvement in LDL, triglyceride, total cholesterol, and HDL. And when it comes to reduction in markers of inflammation, CRP levels are reduced by people who are taking oral semaglutide compared to empagliflozin in this particular study. So CRP is used as a marker of inflammation, generalized inflammation, which is high in people with obesity and people with CVD. And we are also aware of previous trials like the Jupiter, where CRP was taken as a marker for high CV risk and use of rosuvastatin also. So CRP is a marker for this aspect. Now coming to cardiovascular safety of this, Pioneer 6 was a trial which was a CVOT of oral semaglutide. So oral semaglutide was found to be cardiovascular safe in terms of reducing the 3-point MACE. You can see the two lines, and the line with oral semaglutide going below the one with placebo, showing that there are lesser number of cardiovascular events in people using semaglutide in comparison to placebo. And this is the data for stroke. This has been pulled out from the other cardiovascular trials to show that there is a reduction in the risk of stroke in people using oral semaglutide in comparison to placebo. Now, when it comes to safety in people with renal disease, because if you look at your outpatient department, you would realize that 30 to 40% of patients in your outpatient department will have an eGFR of less than 60. So this particular data looks at Pioneer 5 study, which looked at people with an eGFR between 30 to 59. And here, semaglutide worked well in terms of reducing both weight and A1C. Around 3.4 kg reduction in weight in comparison to placebo, and around 1% reduction in A1C in comparison to placebo. So irrespective of your renal function, it continues to work. This data in obese people with type 2 diabetes and CKD, reduction in UACR, albuminuria, and also reduction in progression of renal decline, or rather the rate of eGFR worsening was reduced in people who are using oral semaglutide in comparison to placebo. Now, the final question is, does oral semaglutide hold the promise of becoming one of the prime solutions in diabetes and CVD management? So this is something which we need to address indirectly. We don't have trials looking exclusive for any molecules looking exclusively at the CKM syndrome, but we have various components of CKM syndrome represented in many of the trials that we see every day. So this is the SOUL trial, the oral semaglutide cardiovascular outcome trial, which randomized close to 10,000 patients with type 2 diabetes, aged more than 50 years, established CKD or CVD, and A1C between 6.5 to 10% to oral semaglutide versus placebo. And they looked at purely at the cardiovascular outcomes of this patient. The SOUL top-line results are out, but we don't have the full readout. I think it is happening in these few days to come. So there's a 14% reduction in MACE, that is cardiovascular death, non-fatal MI or non-fatal stroke. All the components had a reduction. As a part of standard of care, 49% of patients received SGLT2 inhibitors. That's a very important point to notice, that we know that SGLT2 inhibitors itself reduce cardiovascular outcomes. So oral semaglutide did that on top of SGLT2 inhibitors. That is one of the major outcomes of this. And it appears to be safe and well tolerated. So if you look at cardiovascular outcome trials of modern glucose lowering agents, I think EMPOWER-H is being discussed multiple times in this meeting. So EMPOWER-H was the first trial to show major benefit. We had CANVAS, we had LEADER, we had REWIND with dulaglutide, and now we have the SOUL data which is there. So you can see that EMPOWER-H is definitely a star, because that was one of the earliest trials to show CV outcomes which was benefited in people with type 2 diabetes. But after that, if you look at LEADER, REWIND, you realize that people using SGLT inhibitors in those trials are not there. When it comes to SOUL, around 50% of patients are using SGLT2 inhibitors. So you are having a cardiovascular outcome benefit on top of SGLT2 inhibitor also in SOUL. Now, there are other ongoing studies. We have the SOUL data which is going to be read out. The SELECT is already out. The FLOW is the renal data of injectable semaglutide. We have the STRIDE data that is looking at peripheral arterial disease, which is ongoing. So looking at various components of the CKM syndrome, so whether it is the heart, where SOUL, SELECT, and FLOW showed that it works. SELECT is for people with obesity without diabetes. Kidney outcomes, both SOUL and FLOW showed benefits. And peripheral arterial disease, we already have SOUL and FLOW as there. STRIDE is set to come, so we'll most probably see benefits in that area also. So to sum up, I've described the close association between metabolic health, cardiovascular, and renal disease in people with type 2 diabetes. I looked at data to show you how oral semaglutide and the entire group of GLP-1 help in improving glycemic control, and how it benefits the cardiorenal and the metabolic areas, including the liver area. This has got multifaceted benefits, and now we have a cardiovascular outcome trial also to support it. Thank you very much.
Thank you, sir, for that wonderful insight on semaglutide. I've got a question for you. Can we use this for any of the age groups? And if so, which dosage forms? 18
is the cutoff. 18 age is the current cutoff for use of oral semaglutide, because all the trials randomize patients above 18 years of age. Dose is similar across the age groups, 3 milligrams, 7 milligram, and 14 milligram. You start at 3, you uptitrate to 7, and then uptitrate to 14.
Injectable?
Injectable is not available in India. It is 1 milligram top dose and 2 milligrams that you can use. That is once weekly. Sir.
Sir, thank you for a nice talk. Sir, in spite of all the technical advantages among the anti-diabetic medicines, like compared with the SGLT2 or DPP4 inhibitors, somehow this is used in a very small number of patients. What is the inhibiting factor? Is it the price or the adverse effects? Suppose if the price is low, does it become an ideal molecule? What is the inhibiting factor?
I think if you look at SGLT inhibitors and GLP-1 RAs, price is in fact one of the major limiting factors, because as you would realize, the usage of SGLT inhibitors have gone up dramatically once the price has come down for dapagliflozin. That I think in the previous talk also you were alluding to that. And now with the empagliflozin prices coming down, that also is going to be more extensively used by doctors. Adverse effects are there, but adverse effects seems to be very small in comparison to the overall benefits that these molecules are providing. Saying that, what you told is again true, because if the price of GLP-1 RAs come down, again, definitely the usage will increase. But as physicians using these drugs, we should be aware of the adverse effects in terms of gastrointestinal adverse effects with all the GLP-1 RAs, and we should judiciously use it in patients. But price, I should say, is going to be the major deciding factor on whether a person is using it. Not only using it, continuing it. That is the most important thing, because most of these benefits are not there if you say take it for 2 or 3 months and stop it. They may not give you any benefits. The benefits come with ongoing use of these molecules. Very true. Price will be the factor.
So one clarification. These drugs, so there are no doubt they are cardiac safe drugs.
Yeah. Yes, sir.
Somewhere the literature says those who have tachycardia,
Yeah.
particularly tachycardia, it's the literature says it can be arrhythmogenic. Is it so?
It is not arrhythmogenic. What happens is, I don't think it has been studied exclusively in studies of tachycardia. It's not been studied, but in general trials, be it the leader or the rewind or the current tirzepatide trials, all these trials, whatever trials you're looking at, there is usually a 2 to 3 beats per minute, or at least 4 beats per minute increase in pulse rate in patients who are using GLP-1 RAs. That is one thing. But overall risk benefit in terms of cardiovascular risk reduction is in favor of these drugs. What you told is true. There is 2 to 3 millimeter reduction in risk benefit. So where is it that we should be having a caution? So there is no contraindication for use in a patient who is having a cardiovascular event, because all these cardiovascular trials have been done in people with events. Suppose you have a patient with severe degree in hospital heart failure, unstable patient, that is not the right patient to go on to GLP-1 RA. So that is one place where I will not use a GLP-1 RA. Inpatient, unstable, heart failure, that patient can get tipped off balance if you have a 3 or 4 millimeter beats per minute increase. For everyone else, it has been found to be safe, sir.
Between GLP-1 RA and SGLT2,
Yeah.
both have many benefits. So which one to start first? I have preferred, or together will they add on benefits, and is it beneficial, and how do we go by sequence?
Yeah. So if you look at the ADA guidelines, if your predominant issue is a chronic kidney disease, if your predominant out in the severe renal spectrum, if your predominant disease is renal, be it increased UACR or increased PC ratio or reduced EGFR, SGLT inhibitor has got the maximum evidence in that aspect. So SGLT inhibitor should come in first. If you look at atherosclerotic vascular disease, suppose you have someone with a carotid artery stenosis or someone with a coronary artery disease, then technically GLP-1 RA should be the first molecule. In the absence of chronic kidney disease, the other thing, it should be the first molecule. But saying that, both these molecules have been found to be beneficial in both the spectrums. So for ease of cost, you would always consider an SGLT inhibitor, and being an oral therapy cost things, you may consider a GLP-1, means a oral SGLT inhibitor ahead in a significant number of patients. So putting it together in terms of scientific evidence, heart failure, 1, renal, 2. These 2 areas, SGLT inhibitors will come first. Atherosclerotic vascular disease, GLP-1 RA will score over SGLT inhibitor. Can you add on both? Yes, you should add on both. If you have a patient who benefits, because the data from SOUL has not been published, but overall benefits show that there is going to be an added benefit. So if you have, and if someone with both CKD is there, after SGLT, you know that once a patient has got CKD, SGLT inhibitors, glycemic efficacy is very minimal. It has got more renal protection than glycemic efficacy. So the next drug add-on will always be a GLP-1 RA if the patient can afford and take it. Thank you.
Thank you so much to the speaker and the chairpersons. I would request the chairpersons to give a small memento to the speaker.